An onlay is always going to make the tooth stronger than an inlay. However, the chances of catastrophic fractures with an onlay are bigger than with an inlay, And I know it's not unanimous. Some of my colleagues, they don't like the fact the composite has a lower elastic modulus, but again, you have to understand a non-vital tooth is a handicapped tooth. So the damping effect, the damping behavior of this occlusal volume of composite in our studies actually proved to protect the remaining tooth structure at the level of the root. With the occlusal veneer, there's no need. Element of biomimetic dentistry is to say that the restoration should be allowed to fail in order to protect the tooth. So zirconia is the opposite.
It finally happened. Finally got Dr. Pascal Magne on the podcast. If you remember, episode 100. I was in Edinburgh at the BACD in the queue to get my book signed by Dr. Magne, and I said to him, please, will you come on the podcast one day? And that day finally came a few years later than I wanted, but we finally made it, guys. And let me tell you guys, you are in for a treat. We're talking about occlusal veneers. How thin can you go? Like, think of a lower molar that is worn and is worn into dentine, possibly because of erosion and attrition, and you don't have much space and you don't really want to prep so much. We can go as thin as, let's say, 0.6 millimeters. And what if I told you you can do it in indirect composite? And that's probably, in many cases, the preferred choice. At the end of the podcast, we discuss the exact protocol of bonding an indirect composite, which actually is also going to help you if ever you're doing a composite repair. How to bond new composite to old composite. Now, we covered so many geeky adhesive and restorative themes, like why not use zirconia? Why is indirect composite a superior choice, especially for your root-filled molars that need cuspal coverage? Which is interesting because I have been doing lithium disilicate for many years, thinking that composite was like a cheaper option, was like a second-rate option. But actually, Dr. Pascal Magne says that if it was his tooth, he'd want indirect composite. Well, you're in the right place to find out why he said that, and also why we should not be so aggressive in capping cusps. Hello, Protrusive, I'm Jaz Gulati, and welcome back to your favorite dental podcast. If you're returning again, thank you so much for being a Protrusive. If you're new to the podcast, you picked a really good one, but I'll tell you what, all our podcasts are awesome, thanks to the wonderful guests we have on. So please don't forget to hit that subscribe button if you like what you hear or see today. Every PDP episode, I give you a Protrusive Dental Pearl, and today's one is, of course, inspired by Pascal Magne and an adhesive protocol tip. The tip is when it comes to the silane step, that step is so critical in whether you're bonding an indirect composite or an indirect ceramic such as lithium disilicate. Once you've done the correct surface preparation of your indirect restoration, so that's different for composite, which you'll hear at the end, and that's different for ceramic. And once you get into the silane stage, here's what you don't do. You don't just apply silane and leave it on the side to let it evaporate. No, you want to let it react for 30 seconds, then you want to air dry it, but then you want to use something like a hairdryer. You need to use some hot air to achieve the perfect layer and the perfect chemistry of your silane. And this surface preparation with a silane is such a critical step that it makes a huge difference in the bond strengths you can achieve. So make sure, guys, that you are air thinning your silane and then you're using some sort of a heat source to achieve that optimal layer. And you'll hear about the geeky justifications and the steps for this towards the end of this podcast. Do not go anywhere, guys. You're going to enjoy this a lot. And remember, our episodes are eligible for CE. This episode is worth 1.25 CE credits, and we are a PACE-approved education provider. On our platform, which is called Protrusive Guidance, the website for that is protrusive.app. That's www.protrusive.app. You'll have access to over 350 hours of CE. This includes the podcast episodes, but also our mini courses and on-demand webinars, which are thoroughly enjoyed by our members. So we'll remind you at the end how to claim CE for this episode and all the others. Let's now join Dr. Pascal Magne to dive deep into occlusal veneers. I'll see you in the outro. Dr. Magne, we had that mentorship session about, 6 weeks ago or something, right? And I didn't tell you this at the time, but I only slept for 2 hours that night because my baby was up and he was very sick the whole night, right? And I was exhausted the whole day. But I knew that I was speaking to you, and my wife could tell that there were the energy levels, as our call was coming, my energy levels were rising again. And it was so great to spend that hour and a bit with you. And it was so great to see you in London last week. You're an absolute inspiration. You're a man who needs no introduction. Like you are, your legacy is so much in academia. You are the author of a most fantastic book. And it's a great pleasure to bring you to the Protrusive Dental podcast. How are you feeling now that you've done a little mini tour of Europe and back home now?
Yeah, I'm good. I'm great. Back to Europe very soon, actually, in a few weeks with the Barcelona 2 days lecture there. But I'm good. I'm good. You know, I travel a little bit less than in the past because now we focus on our center here at home in Los Angeles, Beverly Hills, more precisely, our new center, Magne Education, where I try to focus, on hands-on education. We have also online education. We have a whole bunch of programs. And you see, this is my focus, but I still travel, let's say, approximately 8 times a year overseas for lecturing and different things. Yeah. But otherwise, it's great and exciting to be a dentist in those new times, amazing technology coming out,
You make it
artificial
exciting.
intelligence.
You make it exciting, Dr. Magne. Honestly, with everything that
Thank
you're sharing,
you.
you honestly have that effect. I'm sure you hear that all the time. Today, we're talking about something very cool, occlusal veneers. Like I've done injection molding posteriorly. I have never done these ultra thin occlusal veneers. So I really want to learn a lot more about them. And before I dive in, just as part of the introduction, I want to just heart to heart ask you just one thing, because you've done so much in academia and now you're running your training center, which by the way, just looks spectacular. I hope to visit you one day there as well. Do you miss the academia?
Yes, I have to say there are some aspects of academia that I miss more than others.
Let me guess, your students.
Is my students. Exactly. So, my students, I consider them like my babies, and I've had so much satisfaction teaching, really. Teaching is what I like doing the most. Sharing knowledge. Of course, there is research, but I still do research a little bit less than before. But research was also a big part of my academic life. So having visiting scholars from all over the world join. So I consider them also my students. So yeah, these things I miss a little bit. I don't miss the politics and the committee meetings and all the things, I think that's what's beautiful with aging. To try something positive, to try to find something positive about aging is when you've been successful, you end up choosing more what you like and discarding what you don't like. And again, with age, you come to do more and more what you're good at and less what you are not necessarily good at. And that's always my advice to the young generation, is to focus on your strength, because you will never be good trying to improve your weaknesses. You will never be as good as developing your strength, right? And that's what I think maturity is bringing you to do more and more what you are really good at and less the stuff that are more distractions. Yeah.
It's like niching down, and we talk about that on the podcast a lot, about and finding your niche. Have you ever read this book called Strengths Finder by Tom Rath?
Exactly. That's where I'm getting my inspiration.
Yeah,
I actually did a whole retreat
way.
with my wife, because the goal was to develop the strength in our relationship, right? So
wow.
we both
Lovely.
did the Strength Finder assessment, and then based on that, to try to put our strength together, and coming to the conclusion that if you have the same strength, actually is not an advantage, right? It's better to have different strength in different areas and put them together as a couple. And that's what we learned at this amazing retreat, which was interesting because we did that through the church, but we had to do the Strength Finder assessment, which I really recommend to everybody.
Me too.
If you don't know yet your strength, but by now you should know, right, what you're really good at. And it's the same with the left and the right side of the brain. You remember when I was in London, we talked about that. Some of us are more analytical, temporal, and then some others are more creative, and we have to put that together in the best way possible, and it's called balance, right? It's like in aesthetics, left and right. Left and right side of the brain have to be in balance.
I love how you made that connection, taking it full circle. That was, again, once again, a great lecture in London last week. Today's topic is a hot one, occlusal veneers. But before we get to that, I want to talk about more of a daily scenario, and then I guess we can evolve into occlusal veneers. I bet one of the most common questions that you get asked all the time is, Dr. Magne, when I'm doing an overlay on a lower molar, let's say it has an MOD amalgam, let's say it's root filled, and you've decided that you will be cusp capping the buccal and the lingual, how much should I do my occlusal reduction for my restoration, i.e. how thick should I have my lithium disilicate?
So we've studied that quite extensively, and to be honest with you, it's a very difficult, even with the science, it's a difficult question to answer because it's a little bit, there were a few original studies by a fellow in Holland called Fennis, Fennis, Fennis. And I got a lot of inspiration from his publications. And they were about overlapping versus not overlapping a cusp, which is the everlasting debate, right? When to overlap? What's the residual thickness of the cusp that should be overlapped or not? And dentists, we are very analytical, so we want recipes and we want to say, okay, if the cusp is this amount, I should cover. If it's this amount, I can't keep it, etc. And things are not so mathematical as it appears. And let me tell you why. Mm-hmm. Because we know that the biggest variable in any procedure is the operator and not necessarily the material. Okay, there are choices we have to make with materials, and we'll talk about that. But still, when I look at research articles, the problem I have is, let's say there's an article about overlapping versus not overlapping cusps, weakened cusp, cracked cusps, and they are using a different bonding protocol than my protocol. They are doing an inlay, but without immediate dentin sealing versus an onlay, And now you are not comparing what is actually what you are doing clinically, right? So that's why for a lot of those research, we had to do our own investigations with our own bonding protocols, because as you know, it's all about the protocols and how strict you are with your bonding protocols. And there are so many ways of bonding today. And they are, maybe, I don't know, it was like 10, 15 years ago, we counted like over 100 dentin bonding agents on the market. I'm sure it's much more than that today. Mm-hmm. And most of them are poor products. Let's face it.
I didn't expect you to say that. Wow.
Yeah, there's only, a limited amount of adhesives that have a proven long track record. And so imagine your question is diluted in this whole approach. And what's going to be, you see, for instance, there's a good study by my dear friend Marco Gresnik still in Holland. I tell you, the dentist, some of the professors in the Netherlands are really good. They ask the right questions, and I follow their research. And Marco is also one of my students in the sense that he came to my lab to do some of the research about veneers. And I contributed also to these articles about onlays. And he was showing clearly that if you do an inlay with immediate dentin sealing, this inlay will make the tooth as strong as a non-lay without immediate dentin sealing. You see what I mean? So the stronger you bond, the less those decisions are important, there are equations in adhesive dentistry. Like the stronger you bond, the less important your preparation. The less important is a choice of overlapping versus not overlapping a cusp. The stronger you bond, the thinner your material can be. The stronger you bond, the weaker your material can be. The stronger you bond, the less you need retention, resistance, form. And, today there is all these materials, because there's not only the question inlay versus onlay, but then there is composite versus lithium disilicate versus zirconia versus all of this, right? So the question is huge. And, I would like to say personally, I could pull out articles that say, bond well and you can do inlays even in non-vital teeth. And articles that say, no, an onlay is always stronger than an inlay. And in general, that is true, by the way, that an onlay is always going to make the tooth stronger than an inlay. However, the chances of catastrophic fractures with an onlay are bigger than with an inlay, you know? So when you overlap a cusp, you make the tooth stronger, but when is going to fail in case of overload, in case of overstress, and there is a crack that will initiate, this crack will more likely end up progressing subgingivally and rendering the tooth much more complicated to restore, right? So your question is more like, what is your, choose your poison, in other words. An inlay, more conservative, more, maybe less strong, but more restorable. And that's where I stand personally. Just as a personal story, I have two teeth in my mouth and both upper maxillary molars that had big MOD amalgams. They are very likely the tooth you were talking about. And, I have not an ideal bite like most of the dentists, right? We strive for the best bite for our patient, but we don't take care of our own bite. I am class 2 with overjet and stuff and no anterior guidance. But guess what? I don't have a single root canal treatment yet in my mouth. And to me, that is the victory. That is the victory, is to have all your teeth vital. Because we know that the vital tooth is always a winner and the non-vital tooth is always a loser. And what I like to say is, if you have a non-vital tooth, you cannot win the Olympic Games of restorative dentistry with that tooth. It is a handicap tooth, right? So the goal is really to prevent that first root canal treatment, is to prevent that first crown, is to prevent and be conservative. So just to be honest with you, I would always choose an inlay over an onlay because I can always do the onlay later. It's like, I will always choose a direct composite over a more invasive preparation. Then I can do a more invasive preparation. So we realize that you always want to have one solution left after, right? And you don't want to be in this place where, what do you do after the crown? Usually is extraction, if you have already a root canal, etc. So that's why we stop doing those invasive preps. And I know that and social media is opening so many windows on what is happening in the world with your question precisely, which is onlay versus inlay. And when I see so-called biomimetic dentists advocating aggressive cusp coverage in a way that you end up cutting off intact tooth structure more than you would for an occlusal coverage of a crown, then I would never call that biomimetic anymore. Right? So then there is the topic of thickness of the cusp. So when is it that the onlay is unavoidable, right? When is it that the onlay is unavoidable? For me, for the onlay to be unavoidable, I have to have extremely severe signs of suffering of that cusp. When you see the occlusal surface has been, really beaten down, the enamel is already cracked and crumbling apart. You have cracks going underneath the cusp, visible on the outside of the tooth, from the inside to the outside. Those are signs that, okay, I have to consider the onlay now. The thickness of the cusp to me is rarely the reason, to be honest with you, because we've done some research about super compromised cusps and very thin, only enamel left. But when you do immediate dentin sealing and you restore the cuspal thickness with your buildup, and nowadays we know our latest research is about short fiber reinforced composites like EverX. When you use those material to give back the thickness of the cusp, then your new thickness, if you want, is the one after the buildup. And now you can restore that. You can fill in those undercuts. You can make that cusp strong. Even if you have to wait for this inlay to be processed, whatever is your technique, maybe you have to wait for 10 days or 2 weeks. That buildup with immediate dentin sealing using the right product using the right protocol will make that cusp strong enough for that interim and then the final, strength given by the bonding of your inlay. So back to my story, I had two MOD amalgams on my first maxillary molar that became sensitive because of cracking inside the dentin. So cracked tooth syndrome, enormous pain in biting, air, cold, warm, anything would hurt. And I was like, okay, my time has come for my first root canal, right? No. We bonded it. We did inlays. Actually, back then, I, of course, had a colleague of mine.
Indirect inlays, yeah? It's like ceramic inlays.
Yeah, indirect inlays. They were in composites. I made them myself on a fast-setting silicone model. One was a silicone model. One was a stone model. Anyway, I did my little inlay with my regular clinical composite, nothing fancy, but a hybrid material, micro-hybrid, nano-hybrid style back then. It was 25 years ago, and more. And that was bonded. And guess what? 25 years later, both teeth are still vital. And if you see these occlusal surfaces, I've still kept wearing my teeth. I will be ready soon for my occlusal veneers. But I'm 59 and that may be the next step. Let's not burn the steps. That's my problem today is when we go straight to the invasive solution. And my old mentor, Dr. Belzer, always told me, Pascal, you always need to have a solution left at the end. So don't burn the steps. Don't go too fast and keep, People ask me all the time, this aesthetic is, should I do composite resin, direct, or ceramic veneers? Well, if you are asking, that means start with the composites. Mm-hmm. You can always do the veneers later. And same thing, I look at social media today, and sometimes I feel bad for those patients who received 10, 12 veneers. Now the first molar also veneered, and like a 12 pack of veneers, when that could have been the next step. Not now, not as the first restoration on those teeth, And so we need a lot of wisdom when it comes to those decisions. So I know it's not a short answer to your question, and maybe it's not an answer at all. I don't know, but I would always choose the most conservative solution first, knowing that a failure of that solution will most of the time allow you to still perform the next one. Mm-hmm. So a failure
that does it justice, because we can't just give a number sometimes, right? And you made a great point that, and you taught me this last time in our mentoring session as well, that the inlays that are well bonded following a good protocol, they will significantly reduce that cuspal flexure, and we don't necessarily need to cap those cusps. So for me, that was really good to hear. My only worry is if someone takes that information away, and what do you feel about the situation they're presented with is that the enamel is, like, by the time you remove the caries and the old amalgam, the enamel is now unsupported. There is the full thickness of the enamel, but there's no dentine.
Yes.
Are you still okay to reinforce it with fibers and IDS?
Absolutely.
Okay.
Yes, yes. And actually, one of the studies we did about Everex was about really totally undermining the cusps and using Everex to build back the missing dentin. So Everex short fiber reinforced composites are the best dentin replacement today because of their fracture toughness. I think the team of Dr. Pekka Valitu in Finland, in Turku, they did an amazing job in establishing a standard for the size and shape of those fibers. What they did is really, because, by the way, a short fiber reinforced composite is nothing new. In the 90s, there were at least two materials that I know, Alert and Restolux. They were short fiber reinforced material, but the fibers were chopped so short that the fibers were acting more like a filler rather than a fiber. And Dr. Valitu and his team, they came up with this formula where they say, when the fiber is 70 times longer than the diameter, then it will behave like a fiber. And so that's the value they established for their first product, which was Everex posterior. And we tested this material. I was totally surprised by the results and this material. But then the thing is, with this size of fiber, the material becomes a little bit viscous, and you would have to preheat it to place it. And you could actually not mix it, but combine it with flowable composite so that the areas, and if you have a complex cavity with a lot of little, extensions and stuff, Everex posterior might not go everywhere there. So you want to line first the preparation with a little bit of flowable composite. Now they have Everex Flow. And Everex Flow, by the way, is the only version we have in the US. They officially, Everex posterior is not sold in the US. It's approved by ADA, but not sold. So if you combine Everex Flow to fill the bottom of your preparation, and you can leave it unpolymerized and then use Everex posterior preheated, is easier to place, and you have a wonderful dentin replacement with a material, the fibers of which will act really as a reinforcement. And to me, I would favor that over continuous fiber. I've never been a big fan of continuous fiber. We tried it. We did some research. We could never get the result we got with the short fiber, and it's simpler to apply.
Do we have any clinical data to back this up, of using short fibers to replace the dentine and then having that unsupported enamel and now supporting it with the fibers? Do we have any clinical longevity data?
Yeah, absolutely. And the Turku team, actually, they have clinical data. And now they are even looking at, the next step, which is using, because the flowable material with the very short fiber, the flowable material, the thing is they did a compromise. They made the fibers smaller and shorter. So now the fiber length by diameter ratio is a little bit less for Everex Flow. It's only 30 instead of 70. That's why the material flows more, but there is more fiber inside. And what it is, it makes the material always almost polishable, which is really amazing, because of course, you would never use Everex posterior to the surface of the tooth. But Everex Flow might be possible to use all the way to the surface, and they are investigating that. So, yeah, the results are extremely encouraging. Yes, we need more clinical result, but it's coming. And honestly, I'm very confident based on the in vitro result we got with this material. I really see no reason why the clinical result should follow the same trend. And I think that this is making a huge difference. Now, back to your question, how those inlays are being prepared, the baseliner, what adhesive system you use. All of these are very important parameters in addition to your own hand, right? Mm-hmm. So we have to be careful when we read any research article that we are considering all those elements together, right?
Excellent. And now we can move towards the main topic, which is occlusal veneers, right?
Yes.
So what would you say are the indications for occlusal veneers? Because we said now that in that made up scenario of the lower molar with the MOD amalgam, that actually what the lesson to learn from when you answer that is try to preserve the cusp where possible, unless it's looking like it's stressed. And just on that, actually, if it is stressed and you are going to cap it, how thick do you want your lithium disilicate over that cusp?
Right, exactly. So that was what we studied in a number of studies, especially with my dear ex-student and friend and now colleague and Professor Luis Schlichtig, who is from Brazil, but now teaching at the University of North Carolina in Chapel Hill. And with him, his PhD actually topic was that questions, how thin we can go with those veneers and depending on the material, right? So we started with in vitro data and we did a lot of experiments using different materials from composites to Empress, CAD, Emax, and even some fiber reinforced composite at that time. But anyway, so we went from 1.2 millimeter down to 0.6 millimeter with those veneers. Mm-hmm. And what was really fascinating, because this series of experiments followed another series of experiments when the teeth were non-vital. And we are doing like thick onlays, like 3 millimeter occlusal coverage on non-vital teeth. Simulate a tooth that's really been beaten down. The cusps were already gone, and you do more like endocrown type onlays if you want. And those endocrown type onlays, whether they were in ceramics or composite, we were able, according to our load protocols, we were able to break them. And we have a load protocol that's well established. We start loading those teeth at 200 Newton, then we go 400, 600, 800, 1000, 1200 Newton. We keep ramping the load until we have a failure, right? And usually, I think we went to 12 or 1400 Newton, and then we stop and we see how many teeth survived. Well, with non-vital teeth and those different onlays, we never had teeth surviving the test, right? However, with the occlusal veneers, guess what? We had all the teeth surviving the test, all of them. With the same load protocols, we could not break them catastrophically. And that tells you why. Why? Because in the other group of experiment, the teeth were non-vital. The teeth had lost a lot of structure. We were dealing with what I told you before is called a handicap tooth, a non-vital tooth with a lot of structure lost. So this tooth starts the race really with a huge handicap. The occlusal veneers, we did them on intact wisdom teeth, wisdom molars, with a minimum reduction. So the main coronal structure was intact. Only the occlusal part was substituted with the different materials. So result, because the main structure of the tooth was intact, the pulp roof, the enamel dome, and all that stuff was intact, the teeth survived. No catastrophic failure, not even a fracture of, let's say, a piece of the occlusal veneer coming off. The only thing we observed...
That's why I wanted to ask. I was saying, did the restoration fail, but the tooth survived? But you're saying that actually the entire complex survived.
The entire complex survived. The only thing we were observing was cracks in the restoration. Cracks. And we always considered the cracks more than 3 millimeters, because less than 3 millimeters, really nobody will see them necessarily. Okay? So this is amazing. So that's the first message for you. Whether the veneer was 1.2 millimeter down to 0.6 millimeter. The only thing we could see were cracks. And what was surprising in this case is that the ceramic, even Emax, had more cracks than the composite veneers. So this was really surprising. The composite occlusal veneers, thin ones, displayed very little amount of cracking.
Now, with the composite, then, that's very fascinating. But this is a different beast. I just want people to understand that. Would you have expected the same result if something like, genial injectable was used in a direct technique and then cured through like a stent, but because you were using an indirect composite, that gave it a more superior mechanical properties? Would you expect the same result from direct?
No. Direct composite is a different animal. Direct composite is light cured in the mouth. The degree of cure is not as good as a CAD/CAM milled occlusal veneer like the ones we did. So the degree of cure is less dense. There's porosities, there is imperfections, right? And actually, we also tested that in the previous group of studies with endodontically treated teeth. So by the way, in those studies about thick onlays on endodontically treated teeth, the winner was very clearly the composite. And I like to say on an endodontically treated tooth, I like the idea of having the composite act as a stress absorber. And we had like this effect of absorbing the occlusal load by deformation and protecting the root structure. So with the ceramic, we had more of a stress transfer straight into the root and more subgingival fractures also. So I like the idea of the composite. And I know it's not unanimous. Some of my colleagues, they don't like the fact the composite has a lower elastic modulus. But again, you have to understand a non-vital tooth is a handicap tooth. So the damping effect, the damping behavior of this occlusal volume of composite in our studies actually proved to protect the remaining tooth structure at the level of the root. With the occlusal veneer, there's no need of such a protection if the tooth is pretty intact. Like say, we talk like a tooth that maybe had a root canal like just a little access occlusally, but the endodontist, and you were asking me what are the indications, right? So a typical example is the patient went to endo as an emergency. What do endodontists do? They reduce the cusp immediately to prevent fracture. And now you are missing like 0.5 millimeter of enamel on that cusp, maybe more. And that's where the occlusal veneer is fantastic. Now you have for patients who might not be able to afford an occlusal veneer, you could do also what I call an additive composite. You can extend the composite over the cusp, and if it's well bonded and it's thick enough, it will serve the patient well for many years. And I've done that
But it has to be thick enough.
Patients.
Therefore, if the endodontist has just shaved it 0.5 millimeter, then we're going to have to then shave it down a bit more. So what thickness of composite are we looking for in this additive technique?
When I meant thick enough, I meant in the central aspect, because where are those restorations going to fail? Mainly, in the central groove. And so you want to be very careful. You see, that's another element that makes the question tricky, is about occlusal anatomy. So when you have a very deep mesiodistal groove, there is more chances of the tooth splitting than when you have strong marginal ridges and strong transverse ridges. So when you build your anatomy, it's very important to reproduce those structures. And so that's why we know that, and there's a lot of study by a fellow from Australia or New Zealand, they called Messer, Messer. And they were actually also in Minnesota when I was doing my PhD there. And they show that if you have intact marginal ridges on a posterior tooth, and you have an endo preparation and endo treatment, but the marginal ridges are intact, you need nothing else than an occlusal composite because of the remaining structure protecting the tooth. But it might be that the endodontist has reduced those cusps, and in that case, you could extend the composite, or you could do an occlusal veneer. The occlusal veneer definitely will be a little bit of a plus in terms of protection. And for the choice of the material, that's another important decision. You have to consider occlusion and antagonistic wear. So if the tooth facing that onlay is a natural tooth with enamel, I would always choose composite, because you have to look, there's a very good study about wear of, antagonistic cusps. So you have to look at the wear as a volumetric wear. That's very important, because most studies, they measure wear, height of wear. And you have to understand, and I try to explain that in my book, depth of wear is an occlusal property. Because imagine when you have a very, very pointy cusp, you will lose a lot of height, but not necessarily a lot of volume. When you have a wide cusp, you might lose less height, but still a big volume. So the depth of wear is an occlusal property. But what is characterizing a material is the volumetric wear. So when you look at this study, and there's an excellent study by Kunzelmann in Germany, and they look at enamel wear against different materials, but they look at the volumetric wear, and suddenly you see that enamel against composite, it's 50-50. You will see 50% on one side, 50% on the other side. And the total wear, the additive wear of those two volumes, is always going to be less than with ceramics. So if with ceramics, the ceramic itself will wear itself very little, maybe only 30% of the total wear, but the 70% or more will be the wear of the antagonistic enamel. But the fact is that this 100% of volume loss will be much bigger than with composites. So when people ask me, what is the most biomimetic material in general? I tend to say the most biomimetic material is composite resin. Why? Because composite resin has wear properties very similar to enamel, and elastic modulus, which is the damping behavior of the dentin. So wear and damping behavior. And that's what makes the tooth very unique. The enamel resists wear. The dentin is a damping structure to absorb the deformation. You see, you lead the protrusive podcast, right? Your topic is occlusion, right? So this is modern. I call this modern gnathology. It involves biomaterials, understanding that occlusion is not just cusp touching. Occlusion is the biomechanical response to occlusal stress. And that involves how the tooth deforms under load. Imagine implants now. Implants is a biomechanical challenge because there is no damping behavior except for the supporting bone. And that's why there are some studies that says, oh, short implants are great because they have more flexibility because it's shorter. It gives a little bit more deformation, right? Now, that's not necessarily good for the bone, but it's good for the occlusion because it gives a little give. I always say myself, if I needed an implant one day, I would have a composite resin crown on that implant because we measured that the damping behavior of a composite crown makes that implant respond biomechanically similarly to a tooth with a PDL and intact dentin, etc. So back, I know it's a lot of...
But before you continue though, just the thing that's going through my head, Dr. Magne, is how many dentists in the US and around the world, they see composite as a second grade material. And actually, while you're talking, I've gone back to a podcast I did 3 years ago. It was called Composite Veneers versus Edge Bonding, and we talked about biomimetic dentistry. It was with a very talented British dentist called George Cheetham. And one of the comments was, the words biomimetic and composite do not belong in the same title.
That's interesting.
And so there are these strong opinions that everything has to be lithium disilicate. So it's very fresh to hear your views.
Yes. So my statement was not against ceramics, because there is a room, of course, for ceramics. And when we speak about porcelain veneers, for instance, there's no doubt that nothing can beat porcelain veneer in the long run. When I see my patients 25, 30 years later, the ceramic still looks great. I cannot say that about the composites, right? But again, it's about respecting the steps. And I think that in young patients, adolescents, why would you do veneers in adolescence? This is a nonsense to me. Unless it's a very, very bad, severe problem, general dysplasia of enamel, malformations, severe fluorosis or stuff like that. Otherwise, you can handle a lot. But still, even those cases, you could handle them with composites. But there is room for both, But yes, it is true that my original book was called The Bonded Porcelain Restorations, right?
Yeah.
Because at that time, I have an absolutely outstanding collaboration, with the best ceramist in the world, my brother. And we had this amazing synergy. And by the time I wrote the second book, for different reasons, but one of them was the university not allowing us to work together as brothers because of the trade, basically politics there. I ended up having to do much more work by myself using composites, and that's why my second
indirect composite, just
indirect
for those
and
who
CAD-CAM,
and CAD-CAM,
also CAD-CAM composite. And I guess our research group was one of the first to really go deep into the investigation of CAD-CAM composites when CAD-CAM composites were still called composites. Nowadays, companies call them hybrid ceramics and nano ceramics and this and that. And, they are still fighting the stigma of what you said, which is composite is not biomimetic. Composite is a very poor brother in the field of restorative dentistry. Ceramic is the
poor
noble
man's ceramic,
material.
as they say.
Exactly,
A poor man's ceramic.
ceramics. And now what do you see? You see that here, I think the definition of ceramics was upgraded. You will not believe that, right? I don't know if you are aware, but anything that has more than 51% in content of ceramics can be called a ceramic, which means
That
all our
composites are
composites
ceramic.
are ceramics, according to this new definition. And I believe it's for the coding, because the companies, what they wanted insurance to pay for composite crowns, especially now that we have printed composites, right?
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you enjoyed this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public. And I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates. And also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
So the goal is to have those composite crowns being covered by insurance. And so just put 51 plus something % ceramic content. I believe it's in weight. Which is even worse because the volume would be even less, right? In volume would be 40 something. And then you have a ceramics. And so the thing is, this is important. I'm glad you raised that question. What happened in the 80s? In the 80s, a few companies wanted dental technicians to use composite resins. And in order to make those laboratory materials, companies thought technicians are used to take a brush and ceramics in form of the very fluid paste and put on the teeth. And so they said, we are going to make the composite feel like that, which is a flowable. So they made flowables. And you were maybe not born in those days, but there were a few materials that were complete disaster. One of them was called Targis and Vectris by Ivoclard. It was a fiber-reinforced framework covered with flowable composite. There was a material called Symphony by 3M. There was different material. they were designed to feel like porcelain, but they were flowable composites with less filler, more diluent in the resin, which is more shrinkage, less wear resistance, etc. And so these created and influenced all the data, clinical data, especially produced about composites made in the lab, because those materials behaved really badly. The flowable composites are not designed to be a definitive restoration. So they ended up hurting the scientific pool of data about laboratory-made composites. Nowadays, composites are back in form of CAD/CAM material, which is much, much better. Of course, now they are highly filled, viscous, because they are made in the factory. They can be heat, cured under pressure. So they are really better. And so this revival took time. When 3M came with the first composite block, which is part of the material we studied for the occlusal veneer studies, right? And we had amazing results, Jaz. You will not believe those ultra-thin Z100. It was called Paradigm Z100. The name of the block was the first composite block. They had no commercial success. 3M was actually not even selling the material in Europe, I think only in the US. And this Paradigm Z100 composite never made it really as a commercial success. But we studied it a lot. Dr. Kunzelmann in Germany studied it a lot. And the results were amazing because it's a spheroidal zirconia filler, nanohybrid. Well, back then we called it microhybrid spheroidal, but very wear resistant, strong, amazing. But guess what? The stigma of the 80s about composites did not make this material kind of make the cut. And so the manufacturers decided to switch approach and call those materials ceramics. And the first really of its class was Lava Ultimate, because remember, what material from 3M is called lava zirconia. 3M had a zirconia material. I don't know if they still have it. It was called lava. And they used the name lava for the composite resin, which is basically a new formulation for Filtech material that they came up, during the 90s. And they called it Lava Ultimate, the composite, but they called it resin nanoceramics. So they tried hard. Now we have a new problem. And the new problem is the printed materials. Because the printed materials have low filler content. They have barely above 50%, so that those materials can be sold as a crown material and reimbursed by insurance. But they are not as good as the CAD/CAM materials. And this is going to hurt until we have highly filled printable material. And there's a first step that's been taken by Sprintray with a new system called Midas. I don't know how you call it in the UK. Which has 70% of filler content. So that's good. It's not yet as good as CAD/CAM composites, but it's a first step, and we hope that it keeps developing like that. But meanwhile, I'm afraid that a lot of dentists are going to use printed material as a definitive restorative material for inlays, onlays, crowns, and it's not going to go very well because of the properties of those materials. Personally, I promote printing and for mock-ups and provisionals, and things like that, which is amazing when you do full mouth rehabilitation, when you have to open the bite, deprogram the patient. Printing those onlays and mock-ups is amazing. That's the best use you can do of it. Okay, so
you talked about where, right? And that's when we went into the composite, and you spoke very highly of the fact that that's where the volumetric sort of wear is less with composite. And then we mentioned that, and you gave this history about why composite has a bad rep, but actually it shouldn't be the case. It sounds like if you, God forbid, tomorrow your lower right molar has an amalgam, and then you needed a root canal, that your restoration of choice for your molar may be a indirect composite, just based on what you're saying, right?
Sure.
Now, back
absolutely.
onto ultra thin occlusal veneers. Zirconia, the elephant in the room, the wear of that, when you read the data, when it's like highly polished zirconia, it can be quite kind to the enamel.
Yeah, absolutely. That's true. So that's one of the things with zirconia, because of the structure, and it's so smooth. The wear is not bad at all. Okay. So, but the problem with zirconia is different. The problem with zirconia is it's extremely difficult to adjust. And I would say it might not as predictable for bonding. So you need MDP. MDP will be highly sensitive to hydrolytic degradation, the bond. So, when you bond ceramics, we do two things. We do etching and silane, and there's synergy in there. With zirconia, you don't have that synergy. It's only a chemical bond with the MDP. And so you have to use cements that have MDP like Panavia or specific zirconia primers. You could also use cojet or which doesn't exist anymore, but like CoSil or Siljet from Danville, and you could silicote the zirconia and then use a silane, right? I just want to tell your audience here, don't use silane on zirconia. It will not help. It will not do anything unless you silicote the zirconia by air abrading it with a silicated sand like cojet, CoSil, Siljet, etc. If you are not doing that, the silane is useless. The only monomer that will be useful is MDP. It's a phosphate monomer that's going to covalently bond to the zirconia. But again, that bond is susceptible to hydrolytic degradation. So you are making your life a little bit more complicated. I would like to say, when people ask me about zirconia veneers, what I tell them is if you are used to take your restoration and drop it on the floor, throw it against the wall, step on it, and make those kind of things, then zirconia is perfect for you. You have more chances to have an intact restoration to bond. But if you are careful with your restoration, you really don't need zirconia because the strength is going to be obtained by the bonding. And it's the story. My dear friend Roberto Spreafico from Italy had this funny way of saying it. He said, bench test versus the restoration on the tooth is like the story of the helmet and the wool cap. If you take a helmet and you drop it from the top of a bridge and you let it crash at the bottom there, it will break in pieces, right? You take a wool cap, you drop it from the top of the bridge, and the wool cap will go down and float down, and you take the wool cap, it's intact, right? So you would tend to say the wool cap is better. Of course, the thing is, there is a head together with the hat or with the helmet, right? So a bench test means nothing. So you can have 700 megapascal of flexural strength, but that's not going to help. And actually, like my mentor, Dr. Douglas, was saying, those super strong material, they make the inside of the tooth become hypofunctional. And that the stress that's not absorbed by this part is going to go near the margin into the deeper structure. So we are back to the discussion about the cusp, if you want, right? What is stronger, stiffer, always better? The answer is no, because something will have to give at one moment, and you want the restoration to give, not the tooth, right? And like I was telling in London, this is one of the biggest element of biomimetic dentistry is to say that the restoration should be allowed to fail in order to protect the tooth. So zirconia is the opposite. It's never going to fail because it's so strong by itself, but it's not going to necessarily protect the tooth from failing. And it's a difficult technical material, occlusion adjustments, a contact adjustment.
Well, the issue there is when you do an occlusal adjustment, you're losing that highly polished and now getting a rough zirconia, and then you have to ultra polish it again.
You affect the properties of the material too by doing that.
And you get micro cracks.
It is very complex, and I think zirconia is really, I would consider zirconia mainly for bridge work. That's where you have connections, but this is not biomimetics anymore when you are replacing a missing tooth, right? And I have to tell you, I have huge respect for the works of Matthias Kern in Germany. Kern, who published, so much about resin bonded fixed partial dentures and the long-term results, with simple Panavia on zirconia and one, cantilever pontic, and the results are fantastic. I think many patients in a young age especially should be given that before an implant. and
100%.
look at the implant later. You see, it's always the same principle of wisdom. Let's do the simple stuff first. We can always make it more complicated later. And when we see with implants, the problems of long term. I mean, if you place an implant in a patient in his 20s or 30s, what is going to happen after they are 50, 60? This is big because those implants don't move. So if it's a single implant, you can expect some possible problems. And that's why I would try to delay. I always say if you can wait after age 40, 45 for an implant, that's better.
I totally agree. And I also vouch for huge fan of reservoir and bridges, and especially for lower incisors. Why would anyone do an implant for a lower incisor? It's just when you have great success with reservoir and bridges. Now, back to occlusal veneers, one indication which you kind of touched on when you mentioned about the printed materials being very good for those interim and mock-up and provisional scenarios, which it makes complete sense. But also, when you have the wear patient and you are opening the vertical dimension and they have maybe mostly anterior wear and then their posterior is not very worn, therefore you have that lovely enamel. Now you open the vertical dimension, and classically what someone may do is they may drill the cusps down to give them the correct thickness of the traditional thickness of occlusal veneers, but nowadays we can go very thin, as you've said, with the occlusal veneers, so you can do minimal prep or no prep. How thin can we go with either indirect composite or ceramic?
So according to the studies with Dr. Schlichtig, we went down to 0.6, right? So those were the minimum. But then we have a manufacturing limitations, right? Less than that, it's going to be extremely difficult to have clean margins. And so my question to you would be, when you are getting that thin and the teeth are in good shape, you just use the Dahl principle. You don't restore them, you know? So this is, in your side of the world, this is actually very well known, right? It's much less popular here in the US. There's still a number of dentists who never heard the name Dahl here.
and many lecturers in the US who really frown upon it. They see Dahl as a very sloppy orthodontics. They see it as a sloppy way, whereas we love it here. You know, we are big proponents of it. Like, and same with Scandinavia, as you know.
Yes. So to me, for localized anterior biocorrosion and wear, there's no doubt that Dahl is my go-to most of the time. If posterior teeth do not show any signs of suffering and corrosion or wear, you let them come back together. And, you know, I always say, I don't do Dahl, I do micro Dahl, or sometimes even nano Dahl, because when you look at the original studies in the 70s from Dahl, they were opening those bites enormously, and the patient were hold open with fixed metal appliance, you know, like resin bonded bridges type, and the posterior teeth were left to extrude like millimeters, literally. I do like tens of millimeters of passive, you know, eruption, and that goes very fast. It's a few weeks, a few months at most, and that allows you to just open like a lingual space to place, or direct composites if you have just the notches, you know. Sometimes you have those tight, I call those the tight bites, right? So you get free of a tight bite by opening the bite and deprogramming. Then you place the composite there to hold the bite open while the Dahl principle is happening in the back. To me, this is the best kept secret in full mouth rehabilitation. And you know, if you deprogram, you open the front, there's a gap in the back, you look at this gap. If it's a big gap, you can restore, or you can still do Dahl. If it's a small gap, you can do Dahl, or small tiny direct composites. So I've done low cost full mouth rehabilitation with that technique, which is amazing. And so localized anterior wear biocorrosion, that's my go-to approach. Now, when it's generalized, now you have to look at the anterior relationship, because some cases, so if you have an ideal, when you have generalized wear, biocorrosion, very severe generalized, you might end up in a class 3 situation, right? Because when you lose height quickly, as you can imagine, a class 1 becomes a class 3 by the movement of the mandible, right? So these cases are very easy. You just open them, you recreate anterior overjet, and you restore them. When you have a class 2 in those cases, that's when you have to be a little bit more careful, because if you deprogram, you make the class 2 worse. And so some of these cases might be really indicated to open the bite without deprogramming, so you don't make anterior relationships worse. And so that's why you have to be careful with those cases. But when there is major damage in the posterior, those are perfect indications for occlusal veneers. And as you asked me, yes, we can go down to 0.6.
So yeah, 0.6, but can you, so here's my new knowledge for me. So my understanding is 0.6 on enamel. But in that scenario of the generalized worn dentition, let's say there is a dentine exposure posteriorly, are we still comfortable in having 0.6 millimeters of composite or ceramic on the dentine, which is behaves differently to enamel?
Exactly. And that was the situation, by the way, in the studies we made with Dr. Schlichting. We always exposed the dentine completely occlusally. We were only with a rim of enamel, but the dentine was completely exposed, right? So guess what I'm going to tell you about this question? My answer will be, if you do immediate dentine sealing, and I'm going to be totally clear on that. If you do IDS correctly with the right product, and you know my golden standard is Optibond FL for many, many different reasons. If you do IDS correctly with Optibond FL, we find that basically you are like in enamel. And so that parameter disappears for me. When you handle dentine bonding correctly, which is with immediate dentine sealing, you are in a full enamel situation. And we can say dentine basically disappeared. The moment you do IDS correctly, dentine disappears. You are in an enamel only situation. Patient will not have sensitivity anymore, and you can bond your onlay as you would do if the preparation was only in enamel. That means you clean this prep by air abrasion, etch. You can etch the entire surface. Etching is not going to affect the IDS layer. And then apply fresh adhesive and your bluting composite. And by the way, Jaz, you see, that's another thing. When we are talking about those thicknesses, in our studies, not only we used IDS, but we bonded those thin onlays with a highly filled restorative material. We used a restorative composite as a luting agent. And you can find those articles with Dr. Gresnik that we co-published, where we looked at the strength of thin Emax veneers, anterior veneers, not posterior veneers, but Emax on full dentine preparations. And if you do IDS and you bond them with a highly filled restorative, that will be really a difference compared to bonding them with Relax veneer or Variolinx aesthetics or things like that, which, as I told you, they are not as strong because they are flowable. For a material to flow, you have to pay a cost, which is the filler content or the quality of your resin matrix. So those highly filled materials, we preheat them and we use them as cement. And
can you give an example of which composite to use? Because there's different thicknesses and you can't get the
yes,
thinness
not
enough.
all those composites are created equal. And the problem today is because of the nanotechnology, the nano fillers by themselves make composites very viscous. And in order to fight that problem, manufacturers have to include pre-polymerized filler complexes in the material. Those are bigger chunk of composites. It's pre-polymerized filler. It's made of the same filler, but it's pre-polymerized, ground, and included to decrease the viscosity of those highly filled nano hybrids. Those pre-polymerized fillers can be very big, up to 20, 30 micron. Those material will never work as a cement because those chunks are too big, right? So you have to use more traditional microfill And in a recent article in the Journal of Aesthetic and Restorative Dentistry, we published like tests, about what material will do a decent thickness, film thickness. And amongst those, you have Gradia Direct, you have Transcend by Ultradent, you have Filtech Z250, very surprising. You have APX by Curare. You have INA HRI by Miserium, and there's a bunch of product, but also we notice that some material may become more viscous when you heat them too long. And some product, for unknown reasons to me, have heat initiators. And one of them is APX. APX will work as long as you don't heat it more than 5-10 minutes, I would say maximum. After that, it will start to become more viscous. And it seems it's because of the presence of a heat initiator, which I don't understand to why there would be a heat initiator.
I mean, you've covered so much. And so thank you so much. And it's really nice to hear about indirect composite and how these views about it being a second-rate material, it really needs to change with the data that we have at the moment. So with that in mind now, could you just describe for our listeners the step-by-step protocol of the thin occlusal veneer comes back, which is, let's say, a CAD-CAM composite, the try-in and the risk of it, let's say, breaking during try-in, checking the occlusion. Should we check? Should we not check? And then the actual steps to bond that in as our final question.
Yes, so you always have to keep into account the fact that when you try the restoration, are you going to try just the fit, or are you going to test the occlusion, right? So we did some publications about that. And of course, there is always a risk of breaking the restoration if you let the patient bite. So with thin ceramics, it's a little bit more tricky than with thin composites, because composites, again, has this flexibility that the ceramic doesn't have. So you want to be extremely careful when you do these tests. One thing that will help you a lot is immediate dentin sealing. And do you know why?
No, go for it.
Because when you do IDS, the patient doesn't have sensitivity anymore. The dentin is sealed, is desensitized. So you can test your restoration without anesthesia. And if the patient is not anesthetized, as you know very well, the proprioceptive response is much higher. They will less likely bite strong when you test the occlusion. So IDS will actually be the most important element. You don't need to anesthetize, and your patient is much, much more sensitive to the occlusion and to the biting. And you have less risk of breaking that restoration during the try-in. So that's important. But in general, the beauty is with composite resins, if the bite is a little bit off, it's so much easier to adjust than with lithium disilicate, or even worse with zirconia. So it's not going to be that of a big deal if it's a little bit off with composites. It's going to be a little bit more complicated with ceramic, with zirconia, because then you have to repolish, and repolishing in the mouth is a little bit more labor intensive for those ceramic materials. So in general, I would say yes. If it's an onlay, as we talk, if you look at our studies, you will see that.
Hi friends, just interjecting here. One thing I asked Dr. Pascal Magne, and there was an error with the video, is there a difference in trying in composite versus trying in ceramic, and does it matter if it's an inlay or an onlay? Well, if you take inlays, trying in the mouth a ceramic inlay is a safer bet than trying in a composite inlay. You're more likely to break the composite inlay than the ceramic inlay when you're trying it in. Of course, you have to be careful in either scenario. Now, when it comes to the onlay, interestingly, you're more likely to fracture the ceramic onlay, and the composite onlay is a safer restoration to try in with the occlusion. Why? Because it has more give. More flex. Back to the episode.
Because it's an extra coronal strengthening. Inlays will very likely break at the isthmus between the box and the occlusal surface, especially when you have a very strong, a narrow isthmus like that between the box and the rest of the occlusal. If you have a little high marginal ridge there, that's when you have the most risk of breaking it. So you have to be careful. But here my answer is immediate dentin sealing will give your patient much more sensitivity. And then composite resin will be much more forgivable when you do those try-ins.
And so rubber dam and just are you going to air abrade the intaglio of your CAD-CAM composite?
Yes, so CAD-CAM composites, they need to be treated like an aged composite. Basically, you know, when you repair composites, you have, if you repair a composite that you did recently, you just air abrade, wet with adhesive resin, you're good. If it's a composite that's been in the mouth for 6 months, a year, then you have to air abrade with cojet, silanate, and add adhesive resin. So those materials, CAD-CAM materials, because they are highly polymerized, you have to treat them like a repair. So what I like to do is to air abrade them. I would preferably use cojet. You can use aluminum oxide, but I will preferably use cojet to maximize the effect of the silane. And then you use the silane. And the silane, you have to be careful because this is where there's a lot of misuse of the silane. The silane has to be placed for no longer than 30 seconds wet and then air dried. You never let the silane dry by itself. You have to air dry and heat dry the silane, because when the silane reacts with the filler in those composites, it's going to develop a covalent bonding, and one molecule of water is going to come out of this reaction. It's called a condensation reaction. And that water has to be evaporated along with the alcohol, which is the solvent used in the silane solution. So the hot air is going to make a big difference in the reactivity of the silane, in the covalent bonding, and the hot air is going also to increase the interlayer cohesiveness when you have too much silane on the tooth, which is almost unavoidable. You know, the silane, ideally you would like one layer, one monolayer, with each molecule aligned like a little soldier, with the hydrophilic part against the restoration, the hydrophobic part against the adhesive resin. But you have more than one molecule, they are stacking on each other. And the use of the heat will increase the cohesiveness between those layers of excess silane. But when you leave the silane in excess dry by itself for 60 seconds, for instance, then you create a huge excess of silane. And then more excess means more problems with the cohesiveness of those layers. The good news is when you heat dry the silane, you increase the cohesiveness between those layers, you improve the performance of your silane by 2 times, according to an old study by my dear friend and colleague Jean-François Roulet. So the heat drying of the silane is very important. And then when you use preheated restorative material, it's very important to wet the restoration with adhesive resin. For my part, I use the second bottle of Optibond FL. So the tooth is air abraded and etched, resin coated with Optibond FL bottle number 2. Unless you noticed that you have missed some dentin. In that case, I would apply the primer. But if there is no dentin exposed because you did such a good IDS, you don't need the primer the second time. So etch, air abrade, etch, rinse dry, apply adhesive resin, no polymerization, you don't need. And then on the restoration, you do your air abrasion, preferably with cojet. You can use aluminum oxide, 30 micron, at low pressure, and then cojet if possible. And then you apply the silane for 30 seconds, air dry, heat dry for 1 minute, and then adhesive resin unpolymerized. And then you use the preheated composite as a cement. That's how we did in our study, where those occlusal veneers were unable to fail, if you want, because of the extreme strength of the bone. In the other study about the non-vital teeth with the thicker onlays, what was really amazing is IDS was so efficient that when those onlays broke, the fracture went from the restoration into the tooth straight. There was no failure of the bone. And we took the teeth Actually, when I said none of the teeth survived, it was wrong. We had with the composite resin onlays, like which was Paradigm Z100, we had a number of teeth survive. And when we took those teeth that survived our very demanding occlusal pounding after the test, and we measured the dentin bond strength, the value was still as it was originally in the unfatigued teeth, which is about 57 to 58 megapascal. Remember, the dentin enamel bond strength, biological bond strength, is around 50, 51 megapascal. Mm-hmm. So I'm not telling you we are better than God, but when the bond is so good, the higher the bond, the less it will degrade. So you want to start higher than the dentino-enamel junction because it is going to go down. It is going to go down. It's unavoidable. But the rate of degradation will be less when your original number is very high. If you start at 58, maybe 1 year later, you lost maybe at worst 10%. But when you start at 35, 1 year later, you lost at least 30%. And that's one of the study by Van Merbeek demonstrated in a meta-analytical review of all the adhesives studied on the market. It was about 10 years ago. Number one was Optibond FL. Number two was SE Bond, with the also not only the highest bond strength, but the best stability of the bond.
Amazing. Well, I'm going to summarize this episode in 4 sentences. Number 1, above everything, preserve tooth structure because that is the biomimetic way. Number 2, good quality bonding protocol will allow you to do that and allow you to be biomimetic. Number 3, the importance of IDS and doing that well and how imperative that is for these protocols. And number 4, the use of indirect composites in all these scenarios, especially for root-filled teeth. Thank you so much, Dr. Magne, for spending time with me. It's been a dream to bring you on the podcast. That dream has now been realized. And honestly, I'm so happy to know you and to have this opportunity. Please, can you tell us about the upcoming courses at Magne Education? I know you have so much going on. We'd love to know more.
Absolutely. Thank you for this opportunity. And yes, so we are trying to serve everybody with our courses because I know that for some people, they are more local. They travel easier. Some countries it's really difficult to travel, get visa, and travel organization can be a nightmare. So we have online programs for that. It's called Press Room. And we offer Press Room in the two most common language in this world. Well, actually, I'm wrong. I should learn Chinese maybe, but it's English and Spanish. So we have Press Room once a month. It's a program of 10 sessions, 10 months, and we cover really the essentials of biomimetic restorative dentistry. We have usually 70 minutes, 75 minutes of presentation, and then we have question answers for at least 20 minutes. So it's really nice. It's interactive. And if you miss the day of the live, you can watch it recorded inside our intranet platform. We have a great, by the way, website. We spend a lot of energy on this website, which is the intranet, the portal. And in the portal, we have forum discussions and stuff for each course. It's really nice. So then if you want to visit us, we have our hands-on courses, and one of our flagship courses called the Continuum. This is our mini residency, 5 times 3 days. And we again cover from aesthetics and morphology all the way to the advanced bonding technique and veneers. And then we have what we call summer school. So we do 2 semesters of those continuum courses. And then we have summer school in between, which is extra courses. And in those extra courses, we talk more about customizing your CAD/CAM restoration. For instance, you have a chair-side CAD/CAM system and you want to mill your veneers and you want to be able to maybe even customize your Emacs by yourself. So with a little cutback and micro layering. So this we teach in a course called CAD+. And then we have our extra wear course, which is full mouth rehabilitation of the worn biocorroded dentitions using again, occlusal increase of the vertical dimension and stuff like that, and how to sequence and your treatment plan in a way that's going to be very easy, very common sense, using printed mock-ups or analog mock-ups. I still love analog, but we want to be, surfing the wave of technology. And now with printing, it's amazing. I'm a huge fan of ExoCAD. I'm learning ExoCAD very fast because I think it's an amazing tool for digital approach. And so we will teach ExoCAD, printing, and full mouth rehabilitation. This is CAD, where it's a 3-day course. And we have other stuff.
That's the one I want to come to.
All the information is available on magneeducation.com. And Jaz, you did it yourself. One of my favorite things is what we call mentoring. And you can book with me one-on-one time like we are doing now, if you want. And that's called the mentoring program. It's also available.
I will put the links for that, including Magne Education, in the show notes, so it's easy for you guys to find. I highly condone it. I mean, every time I've seen you speak, you just come back energized, Edinburgh, London, and I really want to come to your full mouth rehab course one day, especially as I'm not doing many of these printed restorations. I'm new to that area. It's so much to learn. So I'll put all those links, and I just want to say thank you so much for everything you do with the knowledge to this world. Thank you.
Thank you, Jaz. It's been a great pleasure, and God bless you and the Protrusive podcast. We love you.
Thank you so much. Well, there we have it, guys. Pascal Magne. It happened and it was awesome. And I'm really hoping you enjoyed it. Loads of gems in there. Look, this is one of those episodes where you need the premium notes. Our premium subscribers can access the PDF transcript and the premium notes, where we kind of summarize everything in an easy to digest way. And what that serves to be is like a rocket for your learning. Like, I know you pick so much up from this episode, but why not increase that retention of information to allow you to apply those techniques to harness the power of the knowledge? And that's where our premium notes absolutely shine. Check out one of our paid plans if you're interested in that. And the way to access it is www.protrusive.app. Now, top tip, visit on your browser, because that's how you can access the 1-week free trial and the best price. Once you've made your login, you can then download our Android or iOS app and then use your newly made login credentials. If you're not already on there, it'd be great to have you in the nicest and geekiest community of dentists in the world. And another one of our mottos is fall in love with dentistry again. It's easy when you've been practicing for many years to eventually get disengaged with work. And what I want my legacy to be with Protrusive Guidance is to allow you to engage with your geeky side, allow you to enjoy your dentistry, allow you to be scientific and proper about your dentistry whilst having fun and satisfaction knowing that you are doing the best for your patients. You'll also get access to the Protrusive Vault, where I'll put all the papers that Dr. Pascal Magne mentioned. I mean, what a guy. Please check out all his educational stuff. I'll put those links to his courses below, so scroll down and you will see them. And thanks so much once again for listening to the end. I'll catch you same time, same place next week. Bye for now.